This
OSP Lahore,
conference will now be recorded.
honorable guests, my esteemed supervisors and fellow colleagues, Assalamu alaikum. My name is Dr. Muhammad Saad Aziz, and I will be the moderator for today's OSP monthly clinical meeting. On behalf of the Board of Directors and Administration of Mughal Hospital Trust, I welcome you all here. It is my humble request to remind all of you to please put your mobile phones to silence so that we can avoid any disturbance. Even better, sir. So before starting our meeting, I would like to request Dr. Hafiz Javed Mansoor Saab to recite a few verses from the Holy Quran.
السلام عليكم. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. اقرأ باسم ربك الذي خلق خلق الإنسان من علق اقرأ وربك الأكرم الذي علم بالقلم علم الإنسان ما لم يعلم. अल्लाह के नाम से शुरू जो बड़ा मेहरबान नहायत रहम वाला है। अपने रब के नाम से पढ़ो जिसने पैदा किया इंसान को खून के लोथरे से बनाया। पढ़ो और तुम्हारा रब ही सबसे बड़ा करीम है जिसने कलम से लिखना सिखाया इंसान को वो सिखाया जो वो ना जानता था। सदक़ल्लाहुल अज़ीम।
Jazakallah. I would now like to invite General Secretary Saab, OSP Lahore, to conduct further proceedings for the meeting.
Bismillahirrahmanirrahim. Thank you, Saad, for your kind words. This is overwhelming to be here, and I would like to extend my deep gratitude to Honorable and worthy MS Mughal Eye Hospital, Dr. Shabazz, and vibrant and energetic and visionary administrator, Colonel Asad, and entire administration of Mughal. And then you have quality and class supervisors, Brigadier Tarak Shakur, Dr. Zahid Rehan, and then you have one of the best pediatric ophthalmologists in that town, Professor Sima Qayyum. My worthy teachers, Professor Dr. Nadeem Hafiz Bhatt, Professor Salim Akhtar, Professor Taiba Gul, Dr. Mateen, Dr. Tahir, Naim Saab, and entire highly skilled and able team of Mughal prestigious gathering from different institutions of Lahore. We are well aware of the fact that professional societies are believed to play a significant role in benevolence and professional growth of its members. So in this regard, we can precisely witness that OSP Lahore has a huge role in uplifting academics across the country through its time-to-time scientific session, in addition to annual gigantic scientific show in the form of annual conference. We have seen OSP Lahore has uplifted and promoted research culture in the country through the introduction of high impact journal PGO and then resident free paper. We can see from the platform of OSP continuous professional development with the help of medical education and leadership development program. And then quiz, wet labs, simulations, live surgery for the trainees, young ophthalmologists, and people working in the remote periphery. These clinical meetings are in fact a sort of formative assessment which allows you to reflect your weakness and then refine for the upcoming summative assessment. And meanwhile, we will welcome to another great teacher and surgeon, Professor Dr. Raza Ali Shah साहब. अगर हम बात करें तो मुगल आई हॉस्पिटल की जो करंट एडमिनिस्ट्रेशन है एक कोहेसिव कोलैबोरेटिव मैनर और प्रोफेशनल मैनर में जिस तरह वो कैन प्रिसाइजली विटनेस द 60% ऑफ अगर आप सब स्पेशलिटी की बात करें कार्निया विट्रोरेटिना सुपरवाइजर बड़ी तादाद से जिस तरह अनदर डॉक्टर जाहिद की वैल्यूएबल एडिशन तो अगर आप देखें चार पाकिस्तान के जो बड़े इंस्टीट्यूशन है टर्शरी केयर जिना म्यू एलजीएच और सिम्स चारों जो है इस वक्त जो है वो फॉर्चुनेटली और अनफॉर्चुनेटली वो रीवैम्पिंग का शिकार है तो ऐसे में क्रेडिट गोज टू द एंटायर टीम ऑफ मुगल की जिन्होंने सारा लोड संभाला हुआ है आप देखें कि सीएसआर एक सीएसआर है सेंट्रल सीरियस रेटिनोपैथी सीएसआर इज द कैटरेक्ट सर्जरी रेट पाकिस्तान में कैटरेक्ट सर्जरी रेट इज बेसिकली कि आप इन 1 ईयर 1 मिलियन जो पॉपुलेशन में द नंबर ऑफ कैटरेक्ट सर्जरी परफॉर्म तो उसका अगर देखें तो पाकिस्तान में दैट रेट इज अराउंड 5300 to 5400 while in our neighboring country it is around 11,000. So SMA credited again to charitable institutions like Mughal and other trust hospital कि जो कि पाकिस्तान के जो इस डेंसली पॉपुलेटेड एरिया और फाइनेंशियल क्राइसिस में जो एक सिग्निफिकेंट जो रोल अपना प्ले कर रहे हैं और सून मेरा ख्याल है कि जिस तरह की जो अंडर द एबल लीडरशिप एडमिनिस्ट्रेशन ऑफ मुगल कि हम सून इसको जिस तरह प्रोफेसर नदीम फीस भट्ट साहब को एक्सपीरियंस है 2 मेडिकल कॉलेजेस के प्रिंसिपल का तो माशाल्लाह इनको एक्सपीरियंस है तो इधर भी सून मेरे ख्याल है हम एमएमसी मुगल मेडिकल कॉलेज शायद जल्दी देखें सो फॉर द फर्दर प्रोसीडिंग आई वुड लाइक टू रिक्वेस्ट स्टाफ टू कंटिन्यू द रिसर्च केसेस थैंक यू अच्छा एक चीज जो बिकॉज ओसी लाहौर हैज ए ट्रेडिशन ऑफ अवार्डिंग सर्टिफिकेट्स एंड सोवेनियर्स टू द टॉप प्रेजेंटर्स इसलिए मैंने रिक्वेस्ट की है हम इस तरह मेडिकल एजुकेशन सर में पढ़ाई हुई है बाइसेस को साइड पे रखते हुए प्रोफेसर सलीम अख्तर साहब प्रोफेसर डॉक्टर रजा अली शाह साहब और डॉक्टर मतीन साहब ये जो है दैट विल बी जज फॉर टुडेज जो केस हमारे प्रेजेंट होंगे थैंक यू वेरी
So thank you very much. Moving on to the scientific session. So on today's agenda, we have 5 very interesting clinical case presentations that have been prepared by our postgraduate residents. The question and answer session shall be conducted by the end of each presentation. So please feel free to ask your questions and share your thoughts. So moving on to our first presentation. So the title of our first presentation is Lifting the Curtain. Let's find out what's behind the curtain with Dr. Aiza Nadeemba.
Thank you so much, Dr. Saad. Assalamu alaikum, everyone. I'm Dr. Aiza Nadeem Bhatt, PGR2 at Mughal Hospital Trust, and today I will be presenting Lifting the Curtain. So, my case is about a 5 years old male resident of Shadra who presented to our OPD on 15th of May 2024 with a complaint of decrease in vision in both eyes, right more than left, since 1 year, progressively worsening since 1 year and associated with on and off redness in right eye since 1.5 years, with no aggravating and relieving factors. Ocular history was unremarkable. Patient had history of occasional knee joint and back pain and skin rashes due to allergy. There was no history of oral genital ulcers, chronic bloody diarrhea, or cough. Patient was on vitamin supplementation for body aches. Allergic history was present, and there was no history of pets. Patient was born to consanguineous parents. He had one brother and one sister, none of whom had similar complaints. Patient was a preterm C-section birth with history of premature rupture of membranes at the time of birth in his mother, and he had to stay in the nursery for 2 weeks. Vaccination was complete according to EPI. Developmental milestones were delayed till the age of 2.5 years, but now patient is developmentally normal. Patient belongs to lower socioeconomic class. On ocular examination, best corrected visual acuity was hand movements in the right eye and 660 in the left eye, reduced bilateral congestion. There was band-shaped keratopathy bilaterally, measuring 9 by 3 millimeter in the right eye and 8 by 3 millimeter in the left eye, obscuring the details of the anterior chamber, pupil, lens, vitreous, and the fundus. This is the picture of our patient showing band-shaped keratopathy. Patient was well oriented in time, place, and person with stable vitals. The limb, lymph node, oral, genital examination was within normal limits. So B scan was ordered as there was obscuration of the details of the posterior segment, which revealed high echoes in the vitreous and flat retina, indicative of vitritis. A surgical plan of bilateral chelation with 2% EDTA under general anesthesia was devised to restore visual acuity, to examine the anterior segment and the posterior segment, and to explore the etiology of the band keratopathy. Commercially, EDTA is prepared by dissolving 11.7 grams of EDTA in 1 liter of distilled water, and the pH is made 8 with sodium hydroxide. Unfortunately, commercial preparation was not available at that time, so we had to prepare the EDTA in our operation theater. We prepared EDTA with two simple things: CBC vial and sterile cotton tip applicator. The wall of the CBC vial is scraped with the help of a sterile cotton tip applicator. The procedure is repeated with 4 vials. One vial contains 5.4 milligram of EDTA and 4 vial contain 21.6 milligram of EDTA. This amount is dissolved in 1 ml of normal saline, creating a 2% solution of EDTA, which is required for chelation. So, the procedure of chelation has 5 steps. First of all, the cornea is deepithelized with the help of a 15 number blade. Then a 2% EDTA soap microsponge is placed on the cornea for 3 minutes until there is sufficient decalcification, and then the cornea is rubbed thoroughly with a sterile cotton tip applicator. Then the cornea is rinsed thoroughly with normal saline to remove the residual EDTA, and bandaged contact lens is applied in the end. This is the pre-chelation picture of our patient, and this is the post-chelation picture of our patient, which shows sufficient clearing of the cornea, and one single posterior synec is also visible, which was very suspicious. So ocular examination post-chelation revealed a best corrected visual acuity of 636 in the right eye and 618 in the left eye. Cornea was bilaterally deepithelized with bandaged contact lens applied. There was AC plus 3 cell reaction in both eyes with irregular pupil and posterior synex. Nuclear sclerosis grade 2 and posterior subcapsular cataract in the right eye, and nuclear sclerosis grade 1 and posterior subcapsular cataract in the left eye. Vitreous haze grade 3 in both eyes, and intraocular pressure of 13 millimeter mercury in the right eye and 14 millimeter mercury in the left eye. So systemic investigations for the underlying uveitis were ordered, of which and patient was kept on follow-up and also referred to the rheumatologist, as patient was a child, and the most common cause of anterior uveitis in children is juvenile idiopathic arthritis. ESR was raised at 18 millimeter per hour, and absolute lymphocyte count was 4.28 into 10 raised per 9 per liter. ANA and RA factor were within normal limit, but that does not still rule out juvenile idiopathic arthritis, because 20 to 25% cases of JIA have normal ANA, and RA factor is also negative in some cases. So, a provisional diagnosis of chronic uveitis leading to band keratopathy was made. Most probably, juvenile idiopathic arthritis was kept in mind as the patient had characteristic symptoms and signs of the disease. Topical treatment for anterior uveitis, including topical steroid, cycloplegic, and non-steroidal anti-inflammatory drug, was started. Further investigations, including toxoplasma IgM and IgG, quantiferon gold, TB, and serum ACE, are awaited. Now, our main goal is to find out the etiology of uveitis and to achieve a quiet eye. Once the eye is quiet, we can carry out cataract extraction in one eye followed by the other eye. Stockerman conducted a research named A Hands-on Approach to Band Keratopathy, in which the prognosis of band keratopathy in patients of chelation was studied, which revealed a 95% symptomatic relief and visual improvement in patients. So, take-home message is that an eye may seem quiet, but it might not be so quiet. Chelation in children should be undertaken promptly so that the underlying pathology can be sought, and it is also a sight-saving procedure. Once the underlying etiology is sought, it can be treated so that band keratopathy does not recur. These are the references. Thank you.
Thank you, Dr. Aiza. So our next case is about whether to go under the knife or not. This can be a very tricky situation, but we have Dr. Rehma Chandre to help us decide. Dr. Rehma.
Thank you, sir. Assalamu alaikum. I'm Dr. Rehma Chandre, a first year resident at Mughal Eye Hospital, and today I will be presenting whether to go under the knife or not. A 7-year-old boy studying in the second grade, resident of Kasoor, presented to us at the OPD on September 2023 with the complaint of drooping of his left upper eyelid and downward deviation of his left eye since birth. The parents had noticed the drooping and deviation shortly after his birth but did not get it checked immediately. He underwent his first eye examination at the age of 1 year, for which no records are available, but the parents informed us that they were advised to not undergo any treatment back then. At the age of 7, he presented to us with the same complaints. The parents were concerned about the cosmetic appearance and wanted a surgical correction. The drooping was not associated with any fatigability or variability throughout the day, nor did the parents notice any aggravating or relieving factors. There's nothing significant in the past history, so we'll move on to the examination. The general physical examination, the vitals were unremarkable. Visual acuity of the right eye was 6/6, while that of the left eye was counting fingers. Ocular examination of the right eye was unremarkable, as indicated by the picture above. While in the left eye, there was drooping of the upper eyelid and an absent lid crease, as indicated by the picture below. The remaining examination was unremarkable. Fundoscopy of the right eye was within normal limits, while in the left eye, there was a tilted disc, a myopic crescent, and a tessellated fundus. Ptosis assessment of the right eye was within normal limits, while in the left eye, the MRD1 was -1 millimeter, levator function was 2 millimeter, and there was a poor Bell's phenomena. The remaining examination is as shown on your tables. So the picture above shows us left ptosis with left hypodeviation compared to the right eye with which the patient is fixating straight ahead at the camera, and the picture below shows us a poor Bell's phenomena in the left eye. The orthoptic assessment revealed left 30-degree hypotropia along with left elevation deficit, as you can see in the picture. We moved on to cycloplegic refraction, and after retinoscopy, the final BCVA was right plane 6/6 and left with correction, counting fingers. So based on this, we made a differential diagnosis of left congenital ptosis with left monocular elevation deficiency, left pseudotosis with left MED, left stimulation deprivation together with refractive amblyopia. And we made a provisional diagnosis of left congenital ptosis with left MED, left stimulation deprivation together with refractive amblyopia. Our management was mainly aimed at the amblyopia therapy. Now, this is done by lifting of the left upper eyelid by taping it, patching the right eye, and spectacle prescription. We counsel the parents regarding the importance of regular follow-up and the adherence to the amblyopia therapy. We planned a forced suction test under general anesthesia. This was done to determine whether the MED was due to restriction of the inferior rectus, paralysis of the superior rectus, or a combination of both of these. Unfortunately, the subsequent follow-ups were not adhered to, and the patient presented to us 3 months later, this time with a complaint of pain and redness in his left eye for 1 week. The patient had undergone surgery for the correction of his concerns at some other hospital. He underwent left nap procedure followed by left frontalis sling procedure 2 months back. The pain was severe in intensity, gradual in onset, non-radiating, associated with photophobia and mucopurulent discharge. This is a picture showing us how the patient presented to us. This picture was taken while the patient was asleep, showing left post-operative nocturnal lag of phimosis. Moving on to the examination. The visual acuity of the right eye was 6.6, while that of the left eye was counting fingers. The remaining examination of the right eye was unremarkable, but in the left eye, there was thrusting of the eyelashes, a partially drooped upper eyelid, diffuse conjunctival congestion, and a 2 by 2 and a 2 by 2 millimeter marginal corneal epithelial defect at 7 to 8 o'clock position that stained positive for fluorescence. The remaining examination was unremarkable, and the fundus findings were as previously described. So these pictures show us the corneal epithelial defect along with the positive uptake of fluorescence. This is how the patient presented to us with a partially drooped upper eyelid and diffuse conjunctival congestion in his left eye. We made a provisional diagnosis of exposure keratopathy secondary to ptosis surgery in an eye with poor Bell's phenomena. Our management began with prescribing the patient topical fortified antibiotics along with lubricants and advising the parents to close the left eye while the patient was asleep by taping it. As the condition improved, we aimed for amblyopia therapy once again, starting with cycloplegic refraction and after retinoscopy, the final BCA was right plane 6.6 and left with correction, counting fingers. We counseled the parents regarding the importance of regular follow-up, usage of the topical medication as and when prescribed, taping of the left eye at night while the patient was asleep, and adherence to the amblyopia therapy. The first follow-up was done after 2 weeks. We reassessed the corneal epithelial defect. The second follow-up was done again after 2 weeks. There was a marked improvement in his condition, so we moved on to cycloplegic refraction and spectacle prescription. This is how the patient appeared on his second follow-up visit. We plan to continue the amblyopia therapy by patching of the right eye and lifting the left upper eyelid by taping it and removal of the sling. An alternative to lifting the left eyelid by taping it is by the use of these ptosis crutches. As you can see, this part over here, this lifts the eyelid. Moving on to the literature review. This was a study done in Al Shifa Eye Hospital, Rawalpindi. Ptosis associated with monocular elevation deficiency, and the key points are: assessment of pseudotosis is important as correction of hypotropia will lead to the correction of the pseudotosis. If there's any residual hypotropia even after NAP procedure, the treatment options include recession of ipsilateral inferior rectus or the recession of contralateral superior rectus. Therefore, it's important to determine if MED is due to any restrictive causes or due to any paralytic causes, whether it's associated with ptosis or pseudotosis. All of this will help in our surgical planning. So the take-home message for today is know the importance about counseling. As in our case, the patient dissatisfaction had led to the loss of his follow-up and an alteration in his management. Thoroughly examine all your patients. Everybody knows how to operate. The key is to know when not to operate. And finally, the amblyopia therapy should not be ignored, as the window for its correction is short, while any cosmetic issue can be addressed later on. These were the references used. Thank you.
Thank you, Dr. Rahma. So, is anti-VEGF a holy grail for every problem? Yes, of course. Or not? Let's find out with Dr. Nurul.
Thank you so much, Dr. Saad. As it's already noon, so good noon, ladies and gentlemen, and assalamu alaikum. My name is Dr. Nurulin, and I'm a postgraduate resident at Mughal Eye Hospital. So, the topic that I'm going to present today reminded me of a medical joke that I heard when I was in my medical school. So, I thought, why shouldn't I share it with you all before I jump into my presentation? So there was this doctor who operated upon a patient, and in the post OR room, he went to the recovery room and said to the patient, Simon, do you know we have a good news and a bad news for you? The patient asked, what is the bad news, doctor? To which the doctor said, we are so sorry, we chopped off your wrong leg. The patient said, what did you do, doctor? Anyways, what is the good news? To which the doctor replied, your diseased leg is getting better on its own. And with this, I start my presentation, and I will be discussing today, is anti-VEGF a holy grail for every problem? I declare no conflict of interest for my presentation. So my patient was this 34-year-old lady, resident of Port Radhakrishnan, married and had three children, who presented to us on 21st of May with a presenting complaint of blurring of vision in both eyes for the past 8 weeks. Probing into the history revealed that my patient had a sudden decrease of vision in both eyes 8 weeks back. She consulted a local ophthalmologist who advised intravitreal anti-VEGF injection ranibizumab after going through few investigations. My patient's vision improved, but the blurriness remained, for which she presented to us on 21st of May. The decrease in vision was sudden in onset, painless, associated with metamorphopsia with no aggravating and relieving factors. When we asked about the medical history, we got to know that my patient was recently diagnosed as a diabetic 5 months ago. She had a history of flu-like symptoms 10 weeks back, for which that lasted for about 7 to 8 days with a spontaneous resolution. My patient was non-hypertensive, and she also had a history of headache off and on. Surgical history was insignificant. Drug history was insignificant. There was no ocular systemic disease in the family. My patient was a non-smoker, non-addict with a normal appetite and a sleep-wake cycle. However, when we did the examination on 21st of May, there was decreased vision in both eyes. The best corrected visual acuity was 6/6 partial in both eyes. Lid, adnexa, and conjunctiva was within normal limits. Cornea was bilaterally clear. Anterior chamber was formed and quiet. She had a bilateral crystalline lens, and the vitreous was bilaterally clear. However, when we did the fundus examination of the patient, this was the picture in which the cup to disc ratio of the left eye was zero point 0.3, and there was this presence of creamy yellow white plecoid lesions typically present at the posterior pole and the equator. Similar lesions were seen in the right eye of the patient with a cup to disc ratio of zero point 0.3. So, on the basis of the history and the clinical examination of the patient, we came to the differential diagnosis of acute posterior multifocal plecoid pigment epitheliopathy, acute multifocal choroiditis, multiple evanescent white dot syndrome, serpiginous choroidopathy, and birdshot choroidopathy. In order to rule out these differentials, we did some investigations that involve the ocular investigations as well as the systemic investigations. The OCT of our patient that was done on 21st May, that was within normal limits. However, when we did the fundus fluorescein angiogram of the patient, here you could see the culprit, the presence of these hypofluorescent lesions in the early phases of FFA that turned into a hyperfluorescent lesions in the late phases of FFA, which did not increase in its size and intensity. Similar lesions were seen in the left eye of the patient. Systemic workup includes CBC, ESR, serum ACE, quantiferon TB, chest X-ray, all of which was within normal limits. So, because of the absence of vitritis and the FFA findings did not correlate with acute multifocal choroiditis, in which there is early hyperfluorescence as well as late hyperfluorescence with staining. But in my patient, there was early hypofluorescence with late hyperfluorescence, and the systemic investigations being negative, the acute multifocal choroiditis was ruled out. Because of the bilaterality of the disease in my patient and the FFA findings did not correlate with multiple evanescent white dot syndrome, MUDS was also ruled out. because the lesions in my patient did not had these typical serpiginous patterns, so serpiginous choroidopathy was also ruled out. The lesions did not have a typical birdshot-like appearance, and because of the absence of vitreous haze, birdshot choroidopathy was also ruled out. So, on the basis of the bilaterality of the disease in my patient, cricoid lesions that were typically present at the posterior pole and the equator, a history of viral prodromal symptoms in my patient, and the FFA findings being typical of early hypofluorescence with the late hypofluorescence that did not increase in size and intensity, we came to the diagnosis of acute posterior multifocal plecoid pigment epitheliopathy. So now with this diagnosis of APM-PPE, the question that arises is, why was intravitreal anti-VEGF injection given in her eye? And the mystery was solved when we asked about the previous investigations of the patient. So this was the investigation that was done by some local ophthalmologists. You could see the increased thickness, but there is the presence of this typical dome-shaped plecoid lesion that is present at the outer retina and the retinal pigment epithelium with hyperreflectivity within, a very typical APM-PPE OCT. So what happened was that the treating ophthalmologist has basically treated that picture of OCT instead of clinically seeing the patient and making a diagnosis. However, on the other hand, after making a diagnosis, he must have looked for the associated systemic features of the patient. So what we did after making a diagnosis, we did look for the associated systemic features of cerebral vasculitis and all the other intracranial pathologies associated with it, and it was within normal limits. So we counsel the patient about the self-limitation of the disease and a very good prognosis. Our literature review shows that APM-PPE is a very self-resolving disease with a very good visual outcome. And there is no role of intravitreal anti-VEGF injection as a treatment for APM-PPE. So what I want to conclude is an increased thickness in OCT is not always an indication for intravitreal anti-VEGF injection, especially when every intravitreal anti-VEGF injection puts the patient to the risk of endophthalmitis, as we all know. Anti-VEGF, although it is a very effective treatment modality for a lot of diseases, but we should know that the patients who actually require anti-VEGF should be sought out very cautiously. So the take-home message from my presentation is residents and even our ophthalmologists should go to the basics, that is history and complete clinical examination before advising sophisticated investigations. Not all the patients with increased macular thickness require anti-VEGF, and all these unnecessary interventional procedures should be avoided. These are the references to my presentation. I started my presentation with a medical joke, and also I want to conclude it with another medical joke that was told to us by our very respected Dr. Zahid Sahab yesterday. And he said that there is only one condition in which there is any indication of intravitreal anti-VEGF injection in APM PPE. Anybody knows what is that? Any guesses? No. So it is when the ophthalmologist's wife wants to go on a shopping. And with this, I conclude. Thank you.
Thank you, Dr. Noor. Moving on to our fourth clinical case presentation, I will request Dr. Zainab to flip over this iceberg for us, please.
Bismillahirrahmanirrahim. An iceberg flipped over. Honorable guests and respected audience,
वो
Assalamu
करेंगे
alaikum. I'm Dr. Zainab Umar, first year resident at Mughal Hospital, and today I'll be presenting a case of a 34 years old young female resident of Sheikhupura. She's married and mother of two. So the chief presenting complaints of the patient were doubling of vision for 1 month, upward deviation of left eye for 15 days, and blurring of vision left eye for 2 days. The past medical and surgical history of the patient was unremarkable. Patient has been wearing glasses for 8 to 9 years. The past drug and family history was insignificant, and there was no history of trauma reported by the patient. So according to the patient, she has been having on and off doubling of vision on down gaze for 1 month. She now noticed an upward deviation of left eye for 15 days, and it was associated with blurring of vision left eye for 2 days. The patient also complained that she has been having on and off vertigo for quite a few years, which she has been ignoring, and it was now associated with projectile vomiting for 2 days. The general physical examination was unremarkable. The best corrected visual acuity in right eye was 6 by 6 and in left eye was 6 by 9. The examination of ocular adnexa and anterior segment was within normal limits. The intraocular pressure was 12 millimeters of mercury in right eye and 13 millimeters of mercury in the left eye. On binocular diplopia testing, the patient reported torsional diplopia on dextrodepression. The pictures were taken with patient's consent. Proceeding with the orthoptic assessment, we notice a slight compensatory head posture of the patient. On Hirschberg, the pupillary reflex was central in the right eye, whereas in the left eye it was displaced 5 to 10 degrees inferiorly and 5 degrees nasally. On covering the right eye, the left eye moved slightly downwards and inwards, and on uncovering, the right eye moved upward to take up the fixation. There was no movement noticed on cover and uncover of the left eye. On squint test, a left eye hypertropia of 12 to 14% diopters was noticed and an alternate exotropia of 6% diopters was noticed. A 10-degree cyclotorsion of left eye was noted on the double Maddox rod, and on Welch-Rosky three-step test, left hypertropia worsened on right gaze and it improved on right head tilt. When we examined the extraocular movements, an inferior oblique overaction of left eye was noted. Rest of the extraocular movements were full and equal, excluding any deficit for third and sixth cranial nerve. Moving on to the optic nerve functions, the RAPD was negative in both eyes. The color vision was 15 by 15 on Ishihara on both eyes. The contrast sensitivity was normal and equal in both eyes. But on the confrontation visual fields, it was normal in all quadrants in the right eye, but in the left eye was slightly constricted temporally. The fundus examination was normal in both eyes with the CD ratio of 0.3 and 0.4 mm respectively with clear disc margins. On the investigations that we advised were Hess test, MRI brain with contrast, and visual field. So as you can see in the Hess test, there was a superior oblique muscle underaction of the left eye, confirming the diagnosis of isolated fourth nerve palsy. The MRI brain with contrast suggested an intracranial mass of posterior cranial fossa. This is the MRI scan of the patient, and the arrows are pointing towards the lesion. If you look at the closer view towards the lesion, the mass was in posterior cranial fossa. It was lying in the midline in fourth ventricle, where it was compressing the brainstem. The mass was then extending superiorly, and it was lying in the occipital region, and it was causing the dilatation of third and lateral ventricles. So the patient was urgently referred to the neurology department, where the patient's BP shunting was done, and a final diagnosis of an intracranial epidermoid cyst was established on MR spectroscopy. So, intracranial epidermoid cyst is basically a congenital lesion. It is a slow-growing mass, and it accounts for only 1% of the total intracranial tumors. This mass typically presents in the middle age due to its effects on the adjacent structures. Next, we perform the visual fields with negligible negative errors and no fixation losses. And there was a slight temporal visual field defect in the left eye. If you look at this diagram, all of the retrochiasmal lesions cause binocular visual field impairment, while the only monocular visual field defect of the contralateral eye occurs when there is a compression or lesion of the most frontal part of calcarine cortex in the occipital area. And this picture was pretty comparable to the MRI of our patient. Here is a similar picture showing the compression of the most anterior part of the occipital cortex, causing monocular visual field defect of the contralateral eye. So a diagnosis of an intracranial mass causing fourth nerve palsy and visual field defects was made. In the management, we referred the patient to the neurology department where her BP shunting was done, and then the patient was further referred to the oncology department where her radiation therapy sessions have been planned. 3 monthly regular follow-up was advised with us. We also advise prisms for the conservative management of diplopia. So the take-home message for today is Complete history taking can lead us to a proper diagnosis. Thorough neurological examination is very important when we are dealing with a single cranial nerve palsy, and an early referral to the concerned specialty will lead to timely management and it can save the patient from ending into some grave complications. These are the references that I have used. Thank you for your patient listening.
Thank you, Dr. Zainab. For the final clinical case presentation, we have Dr. Laiba Asif. Let's see how she bubbles away the cone.
Bismillahirrahmanirrahim. Respected judges and dear audience, Assalamu alaikum. My name is Dr. Laiba Asif and I'm a first year resident at Mughal Hospital, Lahore. And today I will bubble away the cone with you all. So moving on to my presentation, our patient was a 20-year-old male who presented to us with a complaint of decreased vision. The patient was a student by profession and was resident of Hanjarwal, Lahore. So the decrease in vision was gradual and painless in both eyes and it was not associated with any other symptoms. The patient's systemic, medical and surgical history was unremarkable and he had been using glasses for the past 7 to 8 years. We examined the patient and on our clinical examination, the best corrected visual acuity in both eyes was counting fingers. His anterior segment showed us a conical protrusion of the cornea, which was also evident on distant direct ophthalmoscopy, showing us a positive oil droplet sign and scissoring reflex on retinoscopy. So the conical protrusion of the cornea and the thinning of the cornea was present in both eyes with positive Munson sign and presence of Vogt stria in the left eye. The rest of the examination was unremarkable. So we ordered the investigations of the patient, including the corneal topography. Here you can see in the topography maps that there is extreme thinning and steepening of the cornea is present in the right eye, and as well as the left eye there is present the same picture, and we can see that the disaster is in front of our eyes. So now what do? We discussed the management options with our patient. So, are we gonna prescribe glasses to this patient? No, because the disease was quite advanced and the patient had significant difficulty in his both eyes and in his life. So, the next option are rigid gas permeable lenses a good option? Yes, but for this patient we had an issue of non-compliance and patient was also non-willing. So the next option was intracorneal ring segments. The intracorneal ring segments were not an ideal choice for this patient as the corneal thickness was approximately 350 microns in his both eyes and there were issues with affordability. So our final plan was keratoplasty and the procedure we chose was deep anterior lamellar keratoplasty, thus giving my presentation the name bubbling away the cone. The deep anterior lamellar keratoplasty was performed in his right eye in October 2023 and his left eye in February 2024. The surgical technique we used was the big bubble technique. This is the right eye of the patient and you can see the big bubble is being injected in the plane between the Descemet's membrane and the posterior stroma. This is the video of the left eye of the patient with the big bubble being successfully achieved. Next, we dissect away the posterior stroma and we are left with a bare Descemet's membrane after the stromal dissection, which is evident by the presence of an intact air bubble in the anterior chamber. The graft is then prepared by peeling carefully off the Descemet's membrane from the graft. Here you can see that after staining and marking, the Descemet is being carefully peeled off from the graft. Hence, we are left with a Descemet-free graft, which is then sutured onto the host bed. This is the final result after suturing and this shows the right eye of the patient. Moving on, we kept the patient on steroids and kept him under our follow-up. His best corrected visual acuity in the right eye improved to 6/9 from counting fingers. and his left eye improved to 624 from counting fingers with correction. This is the post-op picture in which we can see that the graft is beautifully adhered. The post-op picture in the right eye is at 6 months post-op, and in the left eye is 3 months post-op. So why did we choose lamellar keratoplasty as a procedure of choice as compared to the PKP, which has been standard of care for the past 10 decades, 5 to 6 decades? Over the last 1.5 decades, DALC has been emerging as a mostly preferred procedure because DALC preserves the host endothelium. It gives us a better long-term survival rate of the graft, gives us better long-term endothelial cell counts. It is a closed system operation and does not require an open sky like in penetrating keratoplasty. In terms of best corrected visual acuity and topographic astigmatism, the results are similar in both PKP and DALC. But DALC gives us a decreased risk of complications as compared to the penetrating keratoplasty. Also, we can use a lower quality graft as compared to PKP, which requires a much higher quality graft. These are the references that I used in my presentation. Our patient is still with us in his follow-up and he's a very happy patient. Now he has also given an international language exam and he's very happy with his outcome. Thank you. So the graft in our hospital, the grafts come from Sri Lanka as well as from America, and it is prepared most of the times. But sometimes we have to prepare the graft from by removing the desmids. The DMAC grafts also come prepared as well as this video that I have shown. We use the desmids that we peeled off for another surgery that was DMAC. Uh, Sir Optisol. Thank you.
Thank you, Dr. Laiba. That will be all for our clinical case presentation. The floor is open for discussion. Any questions, please? None. So moving on, I would like to invite our guest speaker to enlighten us with updated guidelines regarding treatment of heart failure. Our guest speaker for today is Dr. Syed Sitanul Hassan. He's a consultant physician, a certified diabetologist and a hepatologist, and in charge of hepatitis clinic at Mughal Hospital, sir. Dr. Syed Sitanul.
थैंक यू साहब फॉर इंट्रोडक्शन एंड अस्सलाम वालेकुम। आपको आवाज़ आ रही है सबको क्लियर? इसे कहेंगे कि आंखों से दिल का सफ़र अब हम करने लगे हैं। आंखें हमने काफ़ी पढ़ ली हैं, उसके बाद हम एक टॉपिक हार्ट फेलियर पे डिस्कस करने लगे हैं। आई एम थैंकफुल टू डॉक्टर शहबाज एंड कर्नल असद फॉर इनवाइटिंग मी और suggesting me for the guest speaker. So today our topic is heart failure. So first we have to resynchronize from eye to heart. Today we will discuss regarding the types of heart failure and the latest treatment regarding the heart failure. WHO targets for 2030 we have to reduce the cardiovascular diseases by one third, but still we are way behind and it looks impossible to reduce it, although it's increasing day by day. It's a pictorial presentation like cardiovascular disease is like elephant in a busy meeting room. We are all busy in our work, but the elephant is also there. So we say cardiovascular disease is a big task to cover. These are some statistics. Heart failure. For heart failure, 1 to 2% of the global population is affected by the heart failure, and we are expecting by 2025, 30% of the global population will have heart failure. It's very progressive. Once it started, symptoms keep on worsening. and it's as deadly as many cancers, and it's costly due to hospitalization, frequent hospitalization. But it can be prevented and treated. Global burden of heart failure is rising day by day. It's like 1 in 5 every individual has a chance of heart failure. Definition of heart failure, we are all aware, we all studying the MBBS. It's a clinical syndrome with symptoms and signs caused by structural and functional cardiac abnormalities. We are we have a prognostic and diagnostic availability available for natriuretic peptide levels. We can diagnose heart failure by that, and by clinical evidence of fluid overload like pulmonary congestion and pulmonary edema. This is the pathophysiology. It all started from here. Actually, we have to prevent these risk factors to break the cycle. So these are the major risk factors: dyslipidemia, hypertension, diabetes, smoking, and obesity. It leads to left ventricular hypertrophy, leads to ischemia, myocardial infarction, and from here the thing starts towards the heart failure. Uh, Heart failure, some facts, heart failure is associated with reduced quality of life, leading to a greater risk of hospitalization of heart failure. We have a New York Heart Association classification for stages of heart failure. There are 4 stages of heart failure, and we will study further. After one heart failure event, the cardiac function keeps declining over the time. So we have to prevent it by the immediate treatment and the lifestyle modification. So every hospitalization leads to the more mortality and more poor prognosis later on. Again, these are the same risk factors. Diabetes on the top. Right now, we are number one in diabetes as per population percentage. Hypertension, valve disease, age, left ventricular hypertrophy, and myocardial infarction. So this is actually the new staging system for heart failure. Previously, we have a New York Heart Association classification. So we have a stage A to D. So we have to prevent the disease at the stage A and B actually to move on to C and D. The, the individual who are at high risk are hypertensive, diabetic, and who have a family history of cardiac disease. Asymptomatic heart failure, those who have developed the myocardial infarction or ischemic heart disease, arrhythmia, or valvular heart disease, they have the probability of getting heart failure very much high. Once you have developed a symptomatic heart failure, you have to keep it under observation and you have to keep it on the medicine and you have a strict vigilance you need. Then there are refractory end stage heart failure, that is a very, very deadly condition. So we have two heart failure definitions and classification. We have a reduced ejection fraction and preserved ejection fraction. So the evolution of heart failure for reduced ejection fraction, we have a definition of American College of Cardiology that the normal ejection fraction actually we all know that the ability of the heart to pump left ventricle to pump the percentage of blood from the heart. So the normal ejection fraction for males is 52% plus minus 5 and in 54% in women. So the cutoff for reduced ejection fraction in all clinical trial was less than 40%, less than and equal to 40%. So any patient comes to you in any OPD with echocardiography report and have an ejection fraction of less than 40%, it means he has a heart failure with reduced ejection fraction. And this is heart failure with preserved ejection fraction. The cutoff value in different clinical trials was different. Initially, it was 40 to 50%. Later on, it was decided that ACC cutoff preserved ejection fraction is greater than 50%. So again, the classification of heart failure by left ventricular ejection fraction is there are three types actually. The new classification have a three types, in which one is reduced ejection fraction, which have left ventricular ejection fraction less than 40%. Then we have preserved ejection fraction, heart failure with preserved ejection fraction greater than 50%. But there is a new classification in which we have a mildly reduced ejection fraction. That is 41 to 49%. So any patient who is falling between the 40 and 50, that's the new comes under the new classification that is mildly reduced ejection fraction. So we have a different treatment plan for all the types of heart failure. So this is how we can diagnose. First is any patient comes to you in OPD and emergency, we have a detailed clinical history, examination, some basic tests, and the hallmark or basic test for heart failure is actually the pro-BNP. This is the test which decides either we have to keep the patient in emergency for long, we have to refer the patient, or we have to either he's a heart failure, fluid overload due to heart failure or due to the kidney disease. So the values of pro-BNP decide if the value is very high, like 2000, then we have to further immediately we have to evaluate for echocardiography and assessment and admit the patient. If the value lies between 400 to 2000, we will keep the patient in emergency and will advise to follow up within 6 weeks. And if the value is less than 400, we will evaluate for the other causes of heart failure. This is the definition for heart failure with preserved ejection fraction. Preserved ejection fraction is a clinical syndrome in which patients have a sign and symptoms of heart failure as a result of high left ventricular filling pressure. So despite normal LV ejection fraction, तो प्रिजर्व्ड इजेक्शन फ्रैक्शन में जो कार्डिक मोटिलिटी होती है उसमें कार्डिक के एलवी साइज से कोई फर्क नहीं पड़ता, उसकी फंक्शनिंग ठीक होती है लेकिन डायस्टली उसकी कम हो जाती है, हार्ट रिलैक्स नहीं करता। तो उसके आगे हम एग्जांपल दिखाते हैं आपको। हार्ट फेलियर विद प्रिजर्व्ड इजेक्शन फ्रैक्शन, inconvenient facts like it's very high probability patient, mostly 50% of the patient, 40% accounts for 50% of heart failure. Heart failure, 1 to 2% of the population will increase informed. Poorest quality of life among chronic diseases and high rate of hospitalization. Diagnosis is challenging because normally the echo we do, we see that ejection fraction is normal. We say you have a normal heart rate. So it's really tough to diagnose. And there is no proven therapy for this. Only diuretics are used for preserved ejection fraction. This is actually the example. The normally heart functions like a balloon. You fill it, well, and then the air comes out, left ventricular, pump the blood out of the heart. But with preserved ejection fraction, it's like a football. You cannot put more gas into the heart or more blood into the left ventricle. So like this patient have a left ventricular hypertrophy. So it the systole is normal, but diastole is weak. So how you differentiate between preserved and reduced ejection fraction? There is only two difference between preserved and reduced ejection fraction. Clinically, they both present the same, like dyspnea, orthopnea, congestive state, pulmonary edema, pedal edema, and but structurally there is a two differences. One is wall thickness, that is preserved ejection fraction. We have a high wall thickness. In reduced ejection fraction, it is reduced, and there is a LV ejection fraction. In reduced, it will be reduced, and in preserved, it will be normal. The other all symptoms are same. So it's very tough to diagnose clinically the preserved and reduced ejection fraction. So this is a young to old leads to cellular aging, oxidative stress, metabolic disease, and leads to heart failure with preserved ejection fraction. There is no difference between preserved and reduced ejection in terms of hospitalization rate, hospitalization duration, and impact on quality of life. So both have the same admission rate and same prognosis and poor prognosis. These are the comorbidities associated with preserved ejection fraction. We have atrial due to enlargement of the left atrium. We have atrial fibrillation, systolic dysfunction, atrial dysfunction, pericardial restraint, and pulmonary hypertension. These are non-cardiac comorbidities associated with preserved ejection fraction, in which we have a type 2 diabetes, obesity, chronic kidney disease, mostly patients with COPD who have a long, prolonged smoking history, and iron deficiency anemia. So these are the same heart failure with preserved. So heart failure preserved ejection fraction patients usually the most common symptoms are dyspnea and exercise intolerance. डिस्निया और चलने फिरने पे सांस का बहुत ज्यादा फूल जाना, सीढ़ियाँ चलने पे. So we have to think about it. And patient complain noisily about something but not able to do anything about it. यानी पेशेंट शोर बहुत करता है लेकिन उसके बारे में कुछ कर नहीं सकता. और इट्स वेरी डिफिकल्ट टू diagnose and treatment. So we have to be very vigilant and vigilant. So again, we will study regarding the natriuretic peptides. Again, we previously discussed this is the hallmark test for fluid overload due to left ventricular failure. So this test decide between either you have a heart failure or not. So these are natriuretic peptides are released in response to the mechanical stress and ischemic injury causing vasodilation, natriuresis, and diuresis. The blood level of BNP, there are two types, BNP and pro-BNP. So BNP level greater than 35 and pro-BNP level greater than 125 are associated with ventricular wall stress. एलिवेटेड लेवल विद स्टेजेस ऑफ हार्ट फेलियर डिफरेंट वेरी करती हैं. जैसे हमने पीछे देखा था कि वैल्यू 2000 से ज़्यादा होंगी तो इट्स वेरी सिग्निफिकेंट. Between the 400 to 2000 we have to observe the patient, and we have also looked for the other causes is below the 600. This is a clinical score for preserved ejection fraction. We usually diagnose on the basis of the clinical presentation. If the patient has body mass index is greater than 30, hypertensive, we have a point for every part, atrial fibrillation, 3 points. So the total score is 0 to 9. If we calculate, so any patient comes with such symptoms and signs of heart failure, we try to diagnose it with this score, either it's a preserved ejection fraction or it's a reduced ejection. So previously, the heart failure definition was systolic and diastolic. Systolic means how it pumps, and diastolic how it relaxes. So later on, it now changes into heart failure with reduced and heart failure with preserved ejection fraction. Again, this is the same classification, and it is the three types: reduced ejection fraction, mildly reduced ejection fraction, and preserved ejection fraction. So this is the thing which we diagnose on the echocardiography. 40% less than is reduced, mildly reduced is 41 to 49, and preserved is greater than 50%. Mortality rate is same, very high for heart failure, same for reduced and preserved ejection fraction, and it's around reaching 50 to 75%. So we have to prevent it with the very earlier stage, at stage A and B. Treatment modalities available for heart failure. So first we will discuss reduced ejection fraction. Previously, our plan of treatment was always a diuretic. Any patient comes with heart failure, we will see patient is in overload. So always we try to control the volume. We give diuretics to reduce the volume of the patient. So that changed the classification of New York Heart Association classification. Any patient comes in emergency with class 4, we give diuretic, patient dyspnea improve, और उस थोड़ी देर में हम ये देखते थे कि उसकी क्लास चेंज हो जाती थी, comes to class 2. Now the plan of treatment is changing. The New York Heart classification, we don't follow that. We follow the stages of heart failure. So heart failure is a cellular disease, and we decide the plan of treatment according to the stage of heart failure. So these are the two examples how we differentiate. Previously, a 64-year-old man presented with left ventricular ejection fraction 35, less than 35. He was admitted to the hospital with a NYHA class 4. We diurease the patient, and suddenly patient class changes to class 2. So it was like classification changed very quickly for the patient. But according to American College of Cardiology, the stage of the disease is stage C. It will remain C either patient symptomatically improve or not. So we will treat and manage the patient according to the stage of the patient rather the New York Heart Association classification. These are the pillars of heart failure drug therapies. We call it Fantastic Four, but latestly the new medicine added is that is SGLT2 inhibitor. This is called actually the miracle drug. In the last 5 years, it changes the spectrum of the disease. So these medication reduce the mortality by 73% in 2 years compared with initially we were using beta blockers and DRAS for prolonged survival for 6 years. These are the summary of heart failure management. We have to change the lifestyle initially, salt control, water intake control. Then we have blood pressure and glucose in a good control. These treatment for less than 40%. So always we give diuretic to remove, to overload the patient is congested, to reduce the overload. And these are the four drugs we already added to that patient immediately and um, receive a response in less 4 weeks. For 41 to 49%, we have a treatment modality for diuretic and SGLT2. SGLT2 is recently added for preserved ejection fraction and mildly reduced ejection fraction. Initially, only diuretics were used for preserved ejection fraction. So, why is rapid initiation important for these medicines for heart failure? So beta blocker reduce the death outcome by 25%. ARNIs, these are ACE inhibitors and neprilysin inhibitors. They reduce the death by 42, hospitalization by 42%. Then we have a spironolactone MRAs reduced by 37%. But the miracle drug came SGLT2. It changes the spectrum of the disease. Now the heart rate, the death and hospitalization reduced by 58% with the only one new single drug added to the heart failure treatment. So clinical benefits of all medications are apparent within 30 days of initiation. So let's the story of SGLT2 in heart failure. In the last 20 years, multiple trials were done, and the two famous trial was DAPA heart failure and the Emperor reduced heart failure. They changed the whole story for the heart failure management. Now the patient with preserved and reduced ejection fraction, SGLT2 is the first line drug in management. So these are the some studies published in the New England Journal of Medicine that the cardiovascular and renal outcome with empagliflozin in heart failure. Mechanism is that it decreases the sympathetic activity, it's natriuretic and osmotic. ये fluid overload भी कम करता है और साथ आपकी बॉडी से सोडियम को भी रिमूव करता है and it improves the reduce the weight of the patient as well. So multiple studies done for left ventricular ejection fraction greater than 40% and less than 40%. So there were 5,500 patients for greater than 40% and 33,500 for 3,350 for reduced ejection fraction. So these are the primary secondary endpoints for the studies for SGLT2 in heart failure. Initially, SGLT2 was only advised for patients with diabetes. Now it changes it. Without diabetes, you can advise SGLT2 inhibitors for the cardiac patient. So it improves the cardiovascular death by 25%. The first secondary endpoint, this is total heart failure hospitalization, less than reduced 30%, and the improvement in kidney function, 50% decrease in renal events by the SGLT2. So this drug is owned by three specialties: nephrologist, cardiologist, and endocrinologist. All say these are these are uh, primary drug of diabetes, but nephrologists say now these are primary drug of kidney disease, and cardiologists say these are primary drugs for cardiology. So we recommend SGLT2 inhibitor in patient with reduced ejection fraction with and without type 2 diabetes to improve the symptoms and the quality of life to reduce the risk of heart failure, hospitalization, and CV mortality. So these changes were made in the treatment of the heart failure that speed matters. You have initially we start one medicine, we go to the maximum dose of that medicine, then add the other medicine. Now that we say we have to start all the medicine all together, and we start. There is no need of any order or sequence of therapy. And this is for heart failure with preserved ejection fraction. Studies are still going on. We have two treatment modalities for heart failure with preserved. We have diuretic and SGLT2. So like this, we have to treat the underlying condition like iron deficiency, atrial fibrillation, hypertension, ischemic disease. So this is a class 1 indication for preserved ejection fraction, and the second one is SGLT2. The other drugs are not very much beneficial, but we have to keep the patient on the medication for the improvement of the symptoms. Same, this is the preserved in left ventricular ejection fraction treatment. Same diuretic SGLT2 is on the top. So some take-home messages regarding the heart failure. So both the European Society of Cardiology and American College of Cardiology established that there are four pillars for the heart failure management. That is ARNI, beta blockers, MRA, and SGLT2. So it is first ever recommendation for mildly the latest guideline. The mildly reduced ejection fraction classification was added. There is a new therapy for heart failure with preserve, that is SGLT2. Very important change in use of therapies for heart failure with reduced. Now we have speed and sequencing. We have to start the medicine all together. So SGLT2 again is a 2A recommendation in heart failure with mildly reduced ejection fraction, and 2B are made for ARNI, ACE, ALB, and beta blockers. There previously we have preserved ejection fraction. We have only diuretics, so we have only used SGLT2 as a first line medicine. So we now staging, we initially studied the stages stage A, B, C, and D. Now we are changing the plan to revise the emphasis for the terminology. We call the stage A patient at risk, and we call pre-hypertension, high heart failure for stage B patients. So this is the new sequencing for previously it was done. We start ACE, then we add beta blockers, then we add MRAs, ARNIs, and SGLT2. Now we keep put the patient on SGLT2 prior, and then we add ARNI and MRA, and all these done should be in 4 weeks to improve the treatment. Thank you for your patience.
Thank you, Dr. Subtan. I would like to bring to your kind attention that Mr. Tariq Mughal Saab, Chairman Mughal Eye Hospital Trust, have just joined us. A very warm welcome to you, sir. Thank you very much for joining us. So that will be all for our scientific session. I hope it was informative and insightful. I would now like to invite General Secretary Saab, OSP Lahore, once again to conduct further proceedings.
Bismillahirrahmanirrahim. Thank you very much, Saad, for all your hard work and commitment in conducting and moderating today's scientific session. I am grateful to Dr. Sultan for illuminating us with your words of wisdom. And we all are aware of the fact that all the international institutions under WEFI accreditation, they have in their curriculum patient safety, interpersonal education, professionalism, and patient safety. So OSP is always on board in this regard. हमारी पिछली जो presentation थी, that was by rheumatologist, and now आपके. And for the residents, you have to be very watchful while injecting peribulbar and while performing FFA. So much of the faculty of Mughal comprises of young consultants starting from आमना से लेके फिज़ा, अक्सा, जुनैरा, और अगर बात करें इधर से अवैस है, अली ताहिर है, नुमान जमशेद है, और himself. So I think we need to give a big round of applause to an entire dedicated team of Mughal for variety of presentation and quality of presentations. And indeed, it must have been a nail-biting experience for the judges as well. So अब मैं इसके लिए रिक्वेस्ट करूँगा वेरी ग्रेट टीचर, ग्रेट सर्जन, ही इज प्रोफेसर ऑफ ऑप्थेल्मोलॉजी एट किंग एडवर्ड मेडिकल यूनिवर्सिटी, प्रोफेसर डॉक्टर रजा अली शाह, कि वो अनाउंस करेंगे पोजीशन होल्डर्स के नाम.
Bismillahirrahmanirrahim. Today the session was excellent, or ہمیں کوئی ڈفرینس محسوس نہیں ہوا کسی جو ہے ٹیچنگ ہاسپٹل اور مغل کے درمیان. اینڈ اٹ واز ون آف دا ویری گڈ پریزنٹیشن سیشن بٹوین یو گائز. اینڈ آپ نے اتنا اچھا پریزنٹ کیا that it was very difficult for the judges to actually nominate who was first, who was second, who was third. Actually, you all stood first. And now, for the sake of this distribution, first of all, I'll announce who is coming third is Dr. Aiza Nadine Butt, lifting the curtain. Excellent presentation, and she talked about the EDTA and how to use and what are the importance and importance of it and how you go about it. And second is an iceberg flipped over. Dr. Zainab Umar. And she talked about the isolated fourth nerve palsy and the mass in the intracranial fossa. And that was a very unique presentation. Again, a very good communication skills also what you have. And the first of is Dr. Noodle N. And she presented very nicely, very efficiently, and the novelty was also there in her and she talked about this AMPPE, that is acute multifocal placoid pigment epitheliopathy, and that not all things are treated by anti-VEGF, so you need to think over it. And very, very, we are happy for all of you that you have presented, and we look forward that you become a very good ophthalmologist and competent doctor. Best of luck. Thank you.
Thank you very much, sir. Uh, we indeed are grateful to our worthy teachers. जिस तरह हमारे पैटर्न प्रोफेसर डॉक्टर लतीफ़ चौधरी उन्होंने सोसाइटी को नर्चर किया विद स्वेट एंड ब्लड, और इसी तरह प्रोफेसर सलीम अख्तर साहब, प्रोफेसर हामिद भट्ट साहब, दे आर ऑलवेज अवेलेबल हमें गाइड करने के लिए, पैटर्नाइज करने के लिए, एम्पावर करने के लिए. So now I would like to request Professor Dr. Hamal Bhatt, Professor Salim Akhtar Saab to come over and present souvenirs, certificates, and cash prizes to the winners. And we are privileged to have Chairman of Mughal Eye Hospital, Tarak Mughal Saab. And मेरे ख्याल है कि indeed we need to give a big round of applause कि मुगल आई हॉस्पिटल में की जो एंटायर एबल लीडरशिप है, जिसमें शबाज साहब हैं, कर्नल साहब हैं, ब्रिगेडियर साहब हैं, जितनी भी, तो इसमें मेरा ख्याल है सबसे ह्यूज क्रेडिट गोज टू द विजन ऑफ तारक मुगल साहब. तो जिस तरह बात का कि जाहिद सब पॉइंट आउट कर रहे थे कि अब अगर आप देखिए वैरायटी ऑफ केसेस, क्वालिटी ऑफ प्रेजेंटेशन, और जिस तरह हमने काफ़ी पैसे खर्च करके मेडिकल एजुकेशन से वो चीज़ें एक्वायर की, CLT कग्निटिव लोड थ्योरी को पढ़ के उन्होंने बच्चों ने अप्लाई किया हुआ था उस पर कि किस तरह आपने विजुअल देने हैं, किस तरह आपने उनको ऑडियंस को किस तरह अटेंटिव रखना है. तो मुगल इज़ वेरी मच कंपेरेबल विद द टर्शरी केयर हॉस्पिटल. एंड जिस तरह मैंने बात की कि जो CSR इज बिकॉज ऑफ मुगल, otherwise we would have been in trouble because of revamping of tertiary care hospital of Punjab. तो सो मैं रिक्वेस्ट करूंगा प्रोफेसर सलीम अख्तर साहब से, प्रोफेसर हामिद भट्ट साहब से और तारक मुगल साहब से आप शबाज साहब और कर्नल साहब आप भी आ जाएं, शबाज साहब आ जाएं, ब्रिगेडियर तारक शूर साहब, मैडम सीमा आप भी आ जाएं, रजा अली शाह साहब भी आ जाएं. सबसे पहले जो अवार्ड हमारा जाएगा फर्स्ट पोजीशन को, और OSP इनको कैश प्राइज भी देती है और सर्टिफिकेट और शील्ड भी. डॉक्टर नूर, डॉक्टर नूर जो है फर्स्ट पोजीशन है, तो उसको अवार्ड दिया जाएगा. सालक और رانا نوید عرفان فہد میرے پیچھے بیٹھے ہوئے ہیں چلیں اچھا یہ سیکنڈ پوزیشن ہے ڈاکٹر زینب کی سیکنڈ پوزیشن کے لیے ڈاکٹر زینب آپ کی جو تھرڈ پوزیشن ہے اچھا تھرڈ پوزیشن کے لیے ڈاکٹر عائزہ ندیم بٹ نمبر 4 پہ جو سرٹیفکیٹ اور سیونگ آئے گی ڈاکٹر رحمان ڈاکٹر لائبہ کی ڈاکٹر لائبہ اچھا ہمارے گیسٹ جو گیسٹ اسپیکر ڈاکٹر سکین اچھا اب میں نے ریکویسٹ کرنی ہے پروفیسر ہارون وڈ بٹ صاحب سے پروفیسر سلیم اختر صاحب سے کہ وہ بوکے پیش کریں فار دا ایکسیلنٹ کلینکل میٹنگ دیٹ از مینیج بائی دا انٹائر ٹیم آف دا مغل تو پروفیسر ہارون محمود بٹ صاحب پروفیسر سلیم اختر صاحب پریزنٹ کریں گے بوکے طارق صاحب کو اور ان کے انٹائر ایڈمنسٹریشن کو
the liberty. I really congratulate. لیکن مجھے سب سے اچھی بات ہے میڈیکل ایجوکیشن از اے پیشن فار می تو میں نے دیکھا پیچھے ایک ڈیڈیکیٹڈ میڈیکل ایجوکیشن کا سیکشن بنا ہوا
زاہد صاحب آپ بھی ہماری جو کلینکل میٹنگ ہے جس طرح میں نے کہا جی کہ ہمارے بڑوں سے لے کے پروفیسر لطیف چودھری صاحب سے لے کے ابھی سینئر اس میں ہمارے جو پیریفری میں ڈاکٹر ارشد صاحب ڈاکٹر طاہر صاحب دے آر پارٹ اینڈ پارسل آف کلینکل میٹنگ ہر دفعہ وہ کلینکل میٹنگ میں ہوتے ہیں اور کسی نہ کسی طرح بیچ میں کنٹریبیوٹ کرتے ہیں تو میں اپنے ٹیچر سے پروفیسر احمد ورلڈ پروفیسر سلیم حسن صاحب ریکویسٹ کروں گا ایک بک ان کو بھی پیش کرنا ہے ہم نے ان کی جو کنٹریبیوشن سگنیفیکنٹ کنٹریبیوشن اور مسلسل حاضری کی وجہ سے ارشد صاحب آپ کو وہ اتنا بڑا ہے کہ دو حصوں میں تقسیم ہو جائے گا باقی جو لاسٹ بٹ ناٹ دا لیسٹ کیونکہ ٹیم ورک کولیبریٹو ایفرٹس اور فارما انڈسٹری کے بغیر ہم بالکل آگے نہیں چل سکتے تو فارما انڈسٹری ہمارے جتنے بھی اکیڈیمک انیشیٹوز ہوتے ہیں یہ ہمیشہ ہمارے ساتھ فور فرنٹ پہ آ کے کام کرتی ہیں تو میں آپ سے ریکویسٹ کروں گا اکمل صاحب سے اور ان کی پوری ٹیم سے کہ ایک بک ان کو ہم نے پیش کرنا ہے فار دا ابھی لنچ آیا نہیں لیکن ہوپ فلی لنچ چلیں تھینک یو ویری مچ فار یور پیشنٹ لسننگ تو اب ہم لنچ کی طرف لنچ لنچ شہباز صاحب